Hi everyone, welcome back to Clear Vision Chronicle, where we make your eye health simple and accessible. In today's video, we'll be discussing an important topic, secondary glaucoma. Yeah, you must have heard about this glaucoma before, but what people don't realize is that secondary glaucoma has its own hidden dangers and unique causes. In today's video, we'll break it down in types, the condition that causes it, and why it is crucial to catch it early. Make sure you stay to the end of this video to get the full picture. Let's dig in. What is secondary glaucoma? These are a group of disorders in which raised intraocular pressure is associated with underlying conditions like systemic disease and primary ocular disease. But we can classify secondary glaucoma into two main ways. 1. Based on mechanism of raising intraocular pressure, and 2. Based on causative primary disease. Based on mechanism of raising intraocular pressure, we have the secondary open angle glaucoma. Here, the drainage angle remains open, but something is blocking or slowing the outflow of aqueous humor. The secondary angle closure glaucoma. In this type, the angle is physically blocked or narrowed, preventing outflow. Based on causative primary disease, we have with papillary block and without papillary block. With papillary block is further divided into two, the lens-induced glaucoma and aphakic glaucoma. The lens-induced glaucoma is divided into two, the lens-induced secondary open angle glaucoma and the lens-induced secondary angle closure glaucoma. But lens-induced secondary open glaucoma is also divided into three, the facultative glaucoma, the lens particle glaucoma, phacoanaphylactic glaucoma. While lens-induced secondary angle closure glaucoma is divided into two, the phacomorphic glaucoma and the phacotopic glaucoma. So let's explain them one after the other. In lens-induced secondary open angle glaucoma, facultative glaucoma is caused by leakage of lens protein in hypermature cataracts, triggering inflammation and blocking trabecular meshwork. This glaucoma was first described by Flux and colleagues and was originally thought to be caused by obstruction in trabecular meshwork. But Epstein et al. Provided evidence for rule of high molecule weight soluble lens protein in causing direct obstruction of aqueous outflow channel. Facultative glaucoma is normally not found in children, and this is because it's been demonstrated that high molecule weight protein are rare in pediatric lenses. For the clinical feature of facultative glaucoma, we have pain, red eye, blurred vision, increase in intraocular pressure, open angle, no visible abnormality, microcytic edema, etc. Diagnosis: facultative glaucoma is a clinical diagnosis. Biochemical studies can help identify high molecule weight lens protein that have been leaked out of cataracts. For the treatment, this case is typically handled as an emergency. Medically, every effort is made to reduce inflammation and IOP using topical steroid and topical suppressants. But definitive treatment for patients with presumed facultative glaucoma is cataract extraction. For the lens particle glaucoma, this is caused by a lens particle entering the anterior chamber, floating in aqueous humor after trauma or surgery, which block the aqueous outflow. Clinical features of lens particle glaucoma are similar to those of facultative glaucoma. Often, lens particle glaucoma has a greater inflammatory component associated with anterior and posterior synechia. Diagnosis: diagnosis is made based on history of recent intraocular surgery or trauma, along with the presence of gross lens material in the anterior chamber. For the treatment of lens particle glaucoma, the severity of disease upon presentation dictates the course of treatment. If minimal corticosteroid material is present, cycloplegic corticosteroid and aqueous suppressants may be employed. However, if inflammation is insignificant and IOP cannot be controlled quickly, urgent irrigation aspiration of lens particle from anterior chamber is necessary. Then for the phacoanaphylactic glaucoma, this is also known as phacogenic glaucoma. It is a rare type of lens-induced glaucoma and often difficult to diagnose in vivo. Phacoanaphylactic glaucoma is a glaucomatous inflammatory reaction that is directed against its own lens antigen after surgery or penetrating trauma, leading to the obstruction of trabecular meshwork and increase in intraocular pressure. The diagnosis of focal anaphylactic glaucoma. This occurs for about 1 to 14 days after cataract surgery and trauma. For the clinical features, keratic precipitate, anterior chamber cell or flare reaction, synechia, residual lens material. The management of focal anaphylactic glaucoma. The initial therapy is to control intraocular pressure and reduce inflammation. If medical treatment is unsuccessful, surgical removal of residual lens material is indicated once inflammation is under control. Talk about lens-induced secondary angle closure glaucoma. In phacomorphic glaucoma, lens swelling, normally seen in advanced cataracts, causes anterior displacement of iris, narrowing the angle and leading to pupillary block. The clinical feature of phacomorphic glaucoma. We have the symptoms as eye pain, headache, blurred vision, perception of arrows around light, vomiting, nausea. For the signs, we have the conjunctival congestion, corneal edema, reduced anterior chamber depth, cell and flare, mid-dilated pupil, intumescent cataracceous lens, significantly elevated pupil. For the management, IOP is reduced using anti-glaucoma medication, but pilocarpine should not be used as it tends to aggravate the pupillary block. For surgical intervention, continuous curvilinear capsulohexis is difficult owing to increase in convexity of anterior capsule due to increase in intraocular pressure, leading to expansion of the tear. For phacotopic glaucoma, this is also known as hypotonias. This is due to lens movements are not rare in ophthalmology. Lens dislocation and subluxation causes pupillary block. The dislocation of lens may directly encroach upon the angle, leading to angle closure. It can occur after a blunt eye trauma or cataracceous lens that has been subluxated. The clinical features include, for the symptoms, we have redness, painful eye, decreased VA, and for the signs, we have the brief pupillary reflex, the clear cornea, the shallow anterior chamber, the angle closure in all quadrants, the subluxated cataracceous lens. For the management and treatment, it can be managed and treated by reducing intraocular pressure. For the second type with pupillary block, we have aphakic glaucoma. This is a glaucoma that develops in an eye without a lens, often due to altered aqueous dynamic and inflammation. Talking about the without pupillary blockage, we have the neovascular glaucoma, the inflammatory glaucoma, the pigmentary glaucoma, the iridocorneal epithelial syndrome, the intraocular hemorrhage, the steroid-induced, the traumatic glaucoma, and the intraocular tumor. Breaking them down one after the other, we have the neovascular glaucoma. This is caused by an abnormal blood vessel growth over the trabecular meshwork, typically due to retinal ischemia, example diabetes, vein occlusion. For the clinical features, we have the hemorrhagic glaucoma, thrombotic glaucoma, rheobotic glaucoma, and congestive glaucoma. Neovascular glaucoma is of 4 stages. We have the prerhombosis, the preglaucoma, the open angle glaucoma, and the angle closure glaucoma. To treat neovascular glaucoma, you have to first of all identify the underlying causes. And once neovascular glaucoma is developed and IOP is high, the major aspect of manage is to control intraocular pressure to prevent optic disc damage and continuous treatment of underlying etiology. For the inflammatory glaucoma, this results due to inflammation like uveitis, which leads to trabecular meshwork damage or peripheral anterior synechia. The inflammatory glaucoma can also be called uveitic glaucoma. It is a disorder in which persistent and recurring increase in IOP results in morphological and physiological alternation of optic disc. Inflammation of ocular tissue is caused by continuous and repeated elevation in intraocular pressure in inflammatory glaucoma. Uveitic glaucoma can be observed in subsequent inflammatory disorders like Business syndrome, diffuse heterochronic iridocyclitis, syphilis, sarcoidosis, juvenile rheumatoid arthritis, scleritis and episcleritis, etc. Treatment of uveitic glaucoma. Treatment of inflammation to prevent formation of posterior synechia and decrease in intensity and frequency of bouts or exacerbation of uveitis. Treatment of glaucoma using anti-glaucoma therapy. Surgery, if needed, is best performed as minor surgery as possible. Recent research has proven the following techniques to be of some value. 1. The laser iridotomy, and 2. Antimetabolite therapy in association with trabeculectomy. For the pigmentary glaucoma, this is caused by pigment dispersion from iris, which block the trabecular meshwork. It is seen in 50% of patients with pigment dispersion syndrome. The clinical features. This condition typically occurs in young myopic males. It is associated with disposition of pigment granules in the anterior segment structures like the posterior surface of the cornea, the trabecular meshwork, the ciliary zonules, and the crystalline lens. For the treatment, we have the medical therapy, the anti-glaucoma drugs, and surgery. Then for iridocorneal endothelium syndrome. This is a rare disorder where corneal endothelium syndrome grows abnormally, obstructing the angle and blocking the aqueous outflows. It's characterized by three entities, which are 1. Progressive atrophy, 2. Chandra syndrome, 3. Cogan-Uri syndrome. Then for intraocular hemorrhage, this occurs when the blood in the anterior chamber, example after trauma or surgery, blocks the trabecular meshwork. It's caused by the prolonged use of topical periocular, intravitreal, inhaled or systemic corticosteroids, which increases resistance to aqueous outflow, causing increase in IUP. For the clinical features, steroid-induced glaucoma usually develop following weeks of topical therapy with strong steroid and months of therapy with weak steroid. For the management, it can be prevented by proper use of steroid and regular monitoring of IOP. The treatment, this consists of discontinuation of steroids. For the traumatic glaucoma, this is caused by damage to angle or trabecular meshwork. This is due to trauma which causes impelled outflow. The management, this consists of medical therapy with topical timolol and oral acetozolamide. The treatment is associated with causative mechanism and surgical intervention according to the situation. For the last one, the intraocular tumor. The secondary glaucoma due to intraocular tumors such as malignant melanoma and retinoblastoma that can compress the angle blocking the aqueous outflow. The treatment, nucleation of the eyeball should be carried out as early as possible. Secondary glaucoma is a diverse and complex condition, but understanding its causes and mechanism is critical for early diagnosis and treatment. I hope this breakdown was helpful. Thank you for joining me on this glaucoma journey. Please don't forget to like, share, subscribe, and stay tuned for more eye health content here in Clear Vision Chronicle. Bye.